Bismillahirrahmanirrahim. Just to introduce myself, I am Professor Zahid Azam. I am Professor of Medicine and Gastroenterology at D.U.H.S National Medical College, Uja campus. I am Professor Syed Mohammad Zahid Azam, Professor of Medicine and Gastroenterology at D.U.H.S National Medical College, Uja campus. Basically, this is a question and answer session which is going to be live, and I'm thankful to the participants who have put their question, which means that they have understood the evaluation. The topic was evaluation of liver function test and its management. So they have understood, and where they were confused or they want some clarity, they have asked questions. Those who were hesitant, I would request them that they should also come forward and ask the questions. They can put this question directly through them with the e-doctor facility, or directly can email me with my email zahid.azam, zahid.azam at duhs.edu.pk. Zahid.azam at duhs.edu.pk. Thank you. So this is a live question answer session of my lecture. E-lecture, evaluation of patients with jaundice and management. So this is the introduction. E-lecture 23 questions from the trainees were asked. So this is the first question. How can we assess the patient of recurrent jaundice? So the assessment of a patient with recurrent jaundice, which means that the patient had jaundice and then it got cleared, and then again he is presented with jaundice. So the commonest scenario with recurrent jaundice is basically Klegler-Najjar and Stevens-Johnson syndrome, as well as other possibilities. So the issue is either hemolysis, or this is because of inappropriate conjugation of bilirubin into the canaliculi in the liver. So either when the person is coming to you with recurrent jaundice, rule out that they do not have hemolytic anemia, which means you get them their retic count, you get their LDH, and if the LDH is high, if the retic count is high, which means that there is hemolysis that is going on, and then you take that pathway, which means this is going to be covered through the hematology part of the lectures, e-lectures. If they do not have high LDH or high retic count, and direct bilirubin is high instead of indirect hyperbilirubinemia, so the causes are different. Suppose this is indirect hyperbilirubinemia, but LDH and retic counts are normal. There is no feature of hemolysis that is reported in your peripheral film, then this may be liver disease. Now coming to second question, after liver transplant, how long the patient can survive? So after liver transplant, majority of the 85 to 90% of the patient, they survive normal life. Once they pass through the initial 3 to 6 months, then the survival is almost as good as a normal person, provided that they are maintaining their immunosuppressive levels adequately and are being monitored regularly. So 5-year survival is 85%. So coming to question number 3, is breastfeeding contraindicated in hepatitis B? Now, any person who has any mother who has hepatitis B, they should continue to feed and don't stop feeding. This is common practice, unfortunately, that people think that when they are going to breastfeed their baby, the virus is going to be transmitted to the newborn. This is wrong concept. Continue with the feeding and encourage breastfeeding. The important thing is you should take care of your nipples, because sometimes what happens then at the time of teething, when the baby is like 7, 8 months, 6 months old, it try to squeeze breast vigorously because of the irritation in the bones in the oral cavity. So at that time you can get abrasion in the breast or nipple. If there is any abrasion with bleeding, you should stop feeding at that time from that breast and continue feeding with the other side of the breast, but don't stop feeding. So there is no contraindication of breastfeeding in hepatitis B or even hepatitis C. The other thing is, the important thing is to control transmission of hepatitis B from the mother to the newborn is मैं अपने what I tell my patient that being Muslim, we have hurry to bathe this child, and then uh, and after that we give them azan. So just like that, you should have urgency to give them at one arm, give them hepatitis B immunoglobulin, and on the other arm you give them hepatitis B vaccination, and that's how you can prevent transmission of hepatitis B from mother to the baby, and there is no contraindication of breastfeeding. So now the question number 4 is role of milk thistle in jaundice. Practically speaking, there is no role of milk thistle in jaundice, and the trials that were done, they were inconclusive. Yes, I understand and I know that people are giving milk thistle in jaundice, in hepatitis B, hepatitis C, and whatnot, but there is no clinical role, there is no scientific role of milk thistle. What should one eat during jaundice and what should avoid? So this is the question. So there is no harm of eating. The problem with acute hepatitis that because of the damage to the hepatocyte, there is a lot of inflammation and there are some mediators that are being released which gives you nausea and vomiting, and that's why you cannot eat. So whatever you can eat, try to eat. Don't get yourself fasting. There is no role of ganne ka juice, sugarcane juice, or any other juice. Continue with lot of sugar containing or drinks, because there is a tendency that you because of there is a tendency of hypoglycemia. So you should take care of this. Avoid very high and rich fat diet at that time, because this is difficult to metabolize. Not with there is nothing with the jaundice. So now question number 6. In cirrhotic patient, how can we prevent esophageal varices? So the development of varices is basically, you need to understand that when your portal pressure increases above 10 millimeter of mercury, then these varices develop. And with the increase in portal pressure further, there is a chance of rupture. So once the portal pressure increases to 12 millimeter of mercury, your varices gets ruptured and you land up with a catastrophic bleed. So our target is basically to halt the process. So how can we halt the process? One and foremost thing is treatment of the underlying cause, which means suppose your patient is suffering from hepatitis C, treat hepatitis C. That's how you cannot reverse cirrhosis, but at least you can halt the process at that period in time where it was. So that's how you can prevent esophageal varices if they have not developed yet. The other thing is like hepatitis B, treat with oral nucleoside or nucleotide analogs. For autoimmune hepatitis, treat them with the steroid. For other cause, address the cause first. The other thing is every patient who is cirrhotic, this is recommended that they should be referred to the gastroenterologist for screening endoscopy for the screening of esophageal varices. So if they did not have esophageal varices, fair enough, continue with the management. If they have small to medium sized varices, treat them with beta blocker, non-selective beta blocker, which may be nadolol, which may be propranolol, which may be carvedilol. So these are the 3 choices that you have if there is no contraindication like bronchial asthma. The other thing is if they have large varices, they have a high propensity to bleed, and that's where you need to subject them to endoscopic band ligation and put them on surveillance. So once you have band ligated them, call them after 3 to 4 weeks for a rebanding, and they need 2 to 3 sessions of continuous 3 to 4 weeks interval bending till the time that there is no more esophageal varices, and then put them on beta blocker, carvedilol, nadolol or propranolol, and continue with them, and then screen every yearly. And that's how you can prevent the esophageal variceal bleed, but you cannot prevent esophageal varices. So the next question number 7. This is, what is the treatment for pruritus of primary biliary cirrhosis? So primary biliary cirrhosis is a condition where there is obstruction of the ductal system, intrahepatic as well as extrahepatic, and you get a lot of pruritus because of bile salt. And you can treat with bile salt resins. So the best treatment is ursodeoxycholic acid. It comes by the name of ursofoc. It comes by the name of urso in Pakistan. It comes by the name of triptor. So start with 250 milligram twice to 3 times a day, and then you increase to 500 milligram ursodeoxycholic acid 3 times a day. So the next question, at what interval LFT should be repeated in viral hepatitis A and E? So acute hepatitis A and E, they are self-limiting condition, and majority of the time you are going to get relief without any specific therapy. LFT should be managed 2 to 3 weeks interval, initially 1 week and then 2 to 3 weeks till they get better. What are the most common causes with which patient present with jaundice in our OPD? So the commonest cause is hepatitis A and E in young people, then obstructive jaundice, which may be because of tumor or stone in the common bile duct, and then the rest is chronic hepatitis B or C, alcoholism and autoimmune rare causes. Next question is, what are differences between primary biliary cirrhosis and primary sclerosing cholangitis? What points in history can help in diagnosis? So very good question. Primary biliary cirrhosis or primary biliary cholangitis is the new term that we use nowadays. So primary biliary cholangitis or PBC, there are markers that tells you that this is PBC versus PSE. So in PBC there is in your ANA profile, you get specific antibodies that are positive, and then for PSE, ASMA is positive, and for PBC, primary biliary cholangitis, AMA is positive. So AMA is positive in PBC, and ASMA, anti-smooth muscle antibody, is positive in primary sclerosing cholangitis. So this is the marker that can differentiate between the two. The other thing is histopathology, so you subject them for ultrasound guided liver biopsy, and for PBC you can get bile duct proliferation, bile duct obstruction, and in PSC you get onion skin appearance of the biliary tree bile ducts. On MRCP or ERCP you can get strictures at different levels in the PSE, primary sclerosing cholangitis, as well as beaded appearance in the PSC. And so these are the points. Then there is a lot of pruritus that is seen in primary biliary cirrhosis or primary biliary cholangitis as compared to primary biliary cholangitis. Majority of the time females are predominantly getting PBC, and males are primary sufferers of PSC. So these are the points that can help you to diagnose PSC versus PSC in cholestatic LFTs. So the next question is, what are the ultrasound finding in primary biliary cirrhosis and primary sclerosing cholangitis? So majority of the time you cannot differentiate based on ultrasound. If they have already set in cirrhosis, you will get just cirrhosis. Sometime in PSC you can get extrahepatic bile duct involvement, so you may get a stricture with dilatation of the intrahepatic bile duct, but that is not specific. Question number 12, can a patient with acute hepatitis take acetaminophen in therapeutic dose for fever and malaise? Very good question, very relevant. And the important thing is you need to understand that acetaminophen, paracetamol, is very toxic in acute hepatitis. So if your patient is suffering from acute hepatitis, try to avoid acetaminophen as much as possible. Majority of the time it's seen that these patients have acute hepatitis, and they present to you with nausea, vomiting, fever. And for fever, this is a knee-jerk reflex that you give them paracetamol, acetaminophen. Avoid this. You can replace and use mefenamic acid or other products like Brufen for pain as well as for fever, but avoid acetaminophen. Because this is very toxic and can lead to acute liver failure, ALF, or in previous days what we used to call FHF, fulminant hepatic failure. Nowadays the term is called ALF, acute liver failure. So it can induce acute liver failure if inadvertently you are giving acetaminophen in a patient with acute hepatitis. The commonest scenario is young person comes to you with nausea, vomiting, and fever, and as a knee-jerk reflex, we give them paracetamol. It takes 3, 5, 7 days to develop jaundice as a natural course of hepatitis B, hepatitis A or E, and then at that time you realize, oh, this is acute hepatitis B. You get their LFT done, which shows ALT or AST in thousands, and bilirubin may be mildly raised. So you should be cautious. The next question is how we treat fatty infiltrates in liver, as it is quite common finding on ultrasound. Fatty infiltrates of fatty liver may be because of several reasons. The commonest reason in West is alcohol. Here in Pakistan or in the East, we have non-alcoholic fatty liver disease. So those people who are not taking alcohol, but still they get ALT and gamma GT, which is high, AST, which is high, and on ultrasound you get fatty infiltrations. So the treatment of fatty liver disease is basically address the cause or the risk factor, and the risk factor for fatty liver is blood pressure, diabetes, high cholesterol or dyslipidemia, obesity, especially truncal obesity, and sedentary lifestyle. So avoid sedentary lifestyle. Ask them to have a regular brisk walk, 30 to 40 minutes a day, at least 5 days a week. Reduce their weight. If they have dyslipidemia or high cholesterol, treat that cholesterol level. Aggressively control blood pressure as well as diabetes, and that's how these are the confounder risk factor that you have controlled. Then the specific therapy for this fatty liver disease is vitamin E in low dose. You can start with vitamin E 400 milligram once a day. It comes by the name of Avion. So Avion 400 milligram once a day at least. For diabetics, you can add other agents as well, but you should be very cautious. The next question is how we can differentiate between intrahepatic cholestasis and extrahepatic cholestasis on clinical and lab finding. So intrahepatic and extrahepatic you cannot differentiate just based on clinical finding or lab finding, because both the intrahepatic or extrahepatic have high bilirubin, which is predominantly direct hyperbilirubinemia, raised gamma GT and alkaline phosphatase, and jaundice on clinical examination. Hepatomegaly may or may not be present, which may be because of tumor, which may be because of acute hepatitis or whatnot. So you cannot differentiate. The only way to differentiate between intra and extrahepatic cholestasis is based on ultrasound. So your ultrasound may differentiate whether you have intrahepatic biliary duct dilatation without any extrahepatic biliary dilation. The commonest scenario is a stone that has slipped into the common bile duct and distal common bile duct. So you have intrahepatic biliary dilatation as well as extrahepatic biliary dilatation, and this is because of a stone. Similarly, cancer of the head of the pancreas may impinge into the common bile duct and could cause intra as well as extrahepatic biliary duct. As compared to, you have isolated intrahepatic biliary duct dilatation when there is a tumor, hilar tumor, infiltrating into the port hepatis, or this may be a gallbladder, and this gallbladder tumor has encroached upon into the hilum, and that's why you get this intrahepatic dilatation without extrahepatic dilatation. So common bile duct, the cutoff for common bile duct, the normal bile duct is 3 to 4 millimeter. Extrahepatic common bile duct, the common bile duct is said to be dilated when you cross a limit of 7 millimeter, and this is based on ultrasound. Question number 15, if hyperbilirubinemia is due to any medication, then how much time will it take to disappear after stopping the medicine? The first foremost thing is, if you're thinking that this is because of medicine, stop the medicine and wait for some time. It depends, it's variable, but at least 3 to 5 days to start decrease, and to have a complete resolution it may take 3 to 4 weeks, sometimes 6 weeks. Sorry. What is the treatment of pruritus in pregnancy? So if you have pruritus in pregnancy, which is because of cholestatic hepatitis in pregnancy, You can use also deoxycholic acid, it's relatively safe. And the definitive therapy is early delivery of this baby. What is the role of nutritional history in adults? What is the role of nutritional history in adults? So, nutritional history is important because suppose if your albumin is low, this may be because of synthetic derangement of the liver versus a patient is starving. Hamare, we are all impressed with Hakims and traditional medicine that they avoid and stop all protein and keep them on Loki and Torai and whatnot. What is the ideal treatment for hepatitis B and C in early stage? In early stage, for hepatitis B, the therapies are different as compared to hepatitis C. This is not the uh, topic that we were discussing. The topic was hepatitis evaluation of liver function tests. So when we come to hepatitis B and C treatment, we can discuss there at that time. What is the prevalence of Dubin-Johnson syndrome and how can we diagnose? Again, this is very rarely seen, and the diagnosis on based on genetic testing. Most of the time, this is not available in Pakistan. Again, not covering the topic, but still, ideally, the question is ideally when we start treatment of hepatitis B after confirmation of PCR. That is going to be covered in hepatitis B topic. Question number 21. Oral treatment is same effective as injectable. I suppose he or she is asking for hepatitis B probably, because the last question was pertaining to hepatitis B, or maybe hepatitis C, I cannot say. If you are talking about oral treatment of hepatitis B, oral treatment of hepatitis B is long term, no definite therapy for 3 years or maybe more, at least 3 years, maybe more. The injectable is time bound, so this is 48 weeks only, once a week, pegylated interferon for hepatitis B. If you're talking about hepatitis C, oral treatment versus injectable, nowadays we are not injecting, we're not giving injectable for hepatitis C. Now we have direct acting antiviral DAAs, which are very good and effective therapy for hepatitis C, and this just one pill a day for 8 weeks to 12 weeks. The next question is what dose of acetaminophen can cause hepatocellular damage? Any dose of acetaminophen when you have acute hepatitis, necroinflammatory process that is going on in the liver, then you get hepatocellular damage. So avoid acetaminophen in acute hepatitis, but there is no contraindication of acetaminophen in chronic hepatitis. Like you are treating cirrhosis or chronic hepatitis C, there is no problem if you can give acetaminophen. The next question is how to differentiate jaundice with hyperkeratonemia. Right. Differentiation is basically based on the genetic testing. Question number 24. Oral treatment is same effective as injectable. Again, the repetition of the question, probably B or C I have discussed. What treatment should be given to chronic hepatitis B patient? I've discussed here again. We were not talking about hepatitis B, but still, can hepatitis B positive mother feed their baby? I've covered this in question number first or second. Yes, you can feed. Is hepatitis B curable? Unfortunately, what we say, once hepatitis B is always hepatitis B. We cannot cure hepatitis B, but yes, we can cure hepatitis C, which means once hepatitis C, you give them drug, HCV-RNA is negative by PCR, check them at 12 weeks time again. If this is negative after completion of therapy, this is called sustained virological response. You say that this is cured. But for hepatitis B, there is always a risk of coming back, because why? This is different from hepatitis C. Okay, hepatitis C can be cured, but hepatitis B can't be cured. Hepatitis B virus is very clever. It gets incorporated into the DNA of the nucleus of the hepatocyte called cccDNA, triple C DNA, and that gets incorporated into the hepatocyte and that causes some changes, and that's why this is needed that every patient who is hepatitis B positive, either carrier, immune tolerant, or immune active, they should be screened or should have surveillance every 6 months with a good quality ultrasound level to rule out hepatocellular carcinoma, as well as they should get 6 monthly alpha fetoprotein. So now question number 28, how and which operative complication can cause hyperbilirubinemia? So considering the operative therapy, this could be, the commonest scenario is you're doing lap chole in your patient, and by inadvertently you have clipped common bile duct. That can cause hyperbilirubinemia as a post-operative complication. Post-operative complication hyperbilirubinemia can be because of this slippage of the stone while you are extracting the gallbladder at the time of laparoscopic surgery or open surgery. A stone can slip into the common bile duct that can cause hyperbilirubinemia and jaundice. Post-operatively, sepsis infection can cause jaundice. Severe sepsis long term can cause jaundice post-operatively. Question number 29, can the people who develop hepatitis A in childhood donate their blood for transfusion later life? Yes, you can donate. There's no problem because there is no chronicity of hepatitis A or E. You can donate blood and there is no problem. Question number 30, how long and how much composition of aspirin can cause liver damage? Aspirin for long term, maybe 6 months and more, and high dose can cause liver damage, but not otherwise as a regular therapeutic dose. What do you say about statins in relation to hepatocellular damage? Do they affect liver cell? Yes, they do affect liver cell sometimes. If you have ALT which is high in a person who is on statins, who is on lipid lowering agent, hold the statins and see if the LFTs gets better. If they are not getting better, this may be other cause. Question number 32, how some patients with hepatitis B surface antigen and antibodies, anti-HBe antigen, are usually symptomatic and have normal liver biochemistry. How to follow these patients? So the question is basically surface antigen positive and E antibody positive, which means they are either asymptomatic carrier and they have normal ALT, normal LFTs. You just keep them on HCC surveillance and get their hepatitis B PCR DNA, hepatitis B DNA PCR every yearly. If your ALT goes high, check PCR at that time, otherwise every year. And if this is high and that comes into the therapeutic range, you treat. In familial hyperlipidemia, what is the role of liver in producing extra cholesterol in bloodstream or some other phenomena? Please explain. So familial dyslipidemia is another condition. You don't get, majority of the time, you don't get T-range LFTs. So initial management, somebody has asked, question number 34, initial management of acute hepatitis. The initial management is symptomatic care, which means that you should take care of their diet. If they are not eating, then this is an indication for admission. Otherwise, majority of the 90-95% of the time, you can treat your patient at home. And if they are dehydrating, then admit them, hydrate them, take care of their sugars, because there is a tendency that there is glycogen storage is hampered, so they can get hypoglycemia. Try to observe their behavior. If they are getting confused and drowsy, which means they are heading towards acute liver failure, transfer them to ICU. In the condition, this ALF can happen in only less than 1%. So the chances are very, very remote, but yes, you should be aware, and if you think that this is ALF, treat them. While waiting for lab results, what treatment shall we give to a patient with acute pain, fever, and jaundice? When there's pain, fever, and jaundice, right hypochondrial pain, fever, and jaundice, and you're suspecting that this is acute hepatitis, avoid acetaminophen, treat with mefenamic acid or ibuprofen, that is brufen. As it is mentioned that acetaminophen and NSAID cause hepatocellular damage, so can we give these patients for acute pain, or what should we give? Acetaminophen, as I mentioned, should be avoided. NSAID, some NSAIDs are very toxic. Relatively less toxic NSAIDs are ibuprofen, but that comes by the name of Brufen, and mefenamic acid that comes by the name of Ponstan. You can give them with caution. Don't give them with empty stomach, give them with the stomach, and cover with PPI to cover for the GI bleed. Question number 37. Initial management of cirrhotic patient before referring to ER who present at a GP clinic with hematemesis. So, if a person is coming to you with hematemesis, this is a medical emergency, this life-threatening emergency, transfer them to the facility where there is good ER, there is endoscopy facility that is available, but at the same time, put them large bore cannula, resuscitate with IV fluid, take care of their airway, and then at the same time give them proton pump, IV proton pump inhibitor. The ideal way would be 80 mg stat and 8 mg per hourly. If you're thinking that this is cirrhotic patient, which you have mentioned in your question, then in cirrhotic patient give them terlipressin after ECG if ECG is available, or at least you should have a monitoring facility. If in monitor there is no ECG changes, give him or her terlipressin 2 mg stat as a bolus push, don't dilute in drip, as a push, 2 mg stat and 1 mg 6 hourly. Next question is what treatment should we start for such a patient before referring for surgery? For hematemesis with GI bleed, cirrhotic patient, they don't go for surgery. The role of surgery is very limited nowadays, and by time, if you buy time with the Sangstein Blackmore tube, or you can refer them for emergency liver transplant. Within our country, this is not possible yet. Can a GP start treatment for hepatitis B, or is it appropriate to refer? Yes, you may start your treatment provided you understand the guidelines, and based on the guideline you can start the treatment of hepatitis B or even hepatitis C nowadays. Question number 40. Clinically, it is possible to differentiate between right upper quadrant pain, that whether it is due to gallstone or peptic ulcer. Clinically, this is very difficult, but majority of the time the typical scenario is right hypochondral pain, which is going to the back as well as to the shoulder blade, and it starts with nausea and vomiting. So this may help you clinically that to decide that this is gallbladder pain, but for this you need an ultrasound, a good quality ultrasound, which is going to pick some features of gallstones. So on ultrasound, if you are thinking that this is gallstone, you can find distended gallbladder, thick wall gallbladder, edematous gallbladder with the stone. So that suggests that this is stone, otherwise this may be acid peptic disease. So question number 41. Does a ball size palpable gallbladder indicate malignancy? This is a law called Corvoiser law, which suggests that if there is any obstruction distal in the common bile duct, either the commonest scenario is head of the pancreas tumor, which can impinge into the gallbladder, which can impinge into the common bile duct and causes distension of the gallbladder. So this is palpable globular gallbladder, the right hypochondrium, which you are able to palpate. This suggests that this may be malignancy. Question number 42. How to diagnose Gilbert syndrome and what is its management? Very good, very relevant question, and as we discussed previously as well, for the workup of jaundice, you need to understand that Gilbert syndrome gives you indirect hyperbilirubinemia, which means suppose your total bilirubin is 3.5, 3.5, direct bilirubin may be 1 and indirect may be 2.5. So this is indirect hyperbilirubinemia. That is a clue. But indirect hyperbilirubinemia may be because of hemolysis. So the workup is basically, and the management is basically to rule out hemolysis. So you get retic count and you get LDH. If they are normal, then you are thinking of Gilbert syndrome. Otherwise, if they are high, then work them up with hematologist. Refer them to hematologist for the workup of hemolytic anemia. Or you can, if you want, you can do the workup further. For Gilbert syndrome, again, the diagnostic test is genetic testing, which is not available in Pakistan. But as you have clearly see that this is indirect hyperbilirubinemia, and there is no, and you have ruled out that there is no G6PD deficiency or hemolysis, then this is Gilbert syndrome. The treatment, further treatment, is basically advise them to have high carbohydrate diet, and they should not be fasting for long. They should have a small snacks or meal in between, and that's how you can also confirm at a follow-up visit that their LFTs get settled. And this is one of the cause of recurrent jaundice, that you get jaundice once you are not fasting and you are taking adequately, the jaundice vanishes. Question number 43. Please explain about the vaccines for hepatitis A and B with a booster dose in adult. For hepatitis A, nowadays this may be given in a newborn along with hepatitis B and other vaccines. You can get hepatitis A vaccine as well separately. These are 2 doses. For hepatitis B, this is 3 doses, 016, which means for adult this is 1 ml intradeltoid day 0, 1 month, and then 6 months from day 0. This is called 016 regime. There is no role of booster nowadays for those people who are exposed to blood, like physicians, nurses, paramedical staff, emergency staff, police, people on dialysis. They need to get their level checked with hepatitis B antibody. If the hepatitis B antibody, surface antibody, is more than 10 international units per ml, then they are protected. There is no role of booster nowadays. Question number 44. How a physician and dental surgeon can protect himself from getting infected with hepatitis B infected patients, apart from adopting safety measures like warning gloves. Hepatitis B is 100% curable and preventable disease. Not curable, but preventable disease. How to prevent yourself? Being physician, being dental surgeon, first thing is get yourself vaccinated and get your levels checked. So I told you 3 doses, 016, intradeltoid 1 ml. Get yourself vaccinated. You are not going to get, if you get break or cut, you're not going to get hepatitis B, inshallah. And yes, I understand that safety measure, universal safety precaution is always needed, despite you are vaccinated against hepatitis B, because there is no vaccine nowadays till now for hepatitis C or HIV. So adopt safety measures like gloves and mask. Question number 45. What treatment should be given to liver abscess patient at GP level? If you can treat at GP level if the patient has liver abscess on ultrasound, they are not too much toxic. Treat them with oral metronidazole 800 milligram. You can use entamizole DS, which is a combination of diloxonate as well as metronidazole. And if you're thinking of pyogenic liver abscess, add along with anaerobic cover, add with cefixime. Or you can give them at home or at your clinic 2 gram ceftriaxone once a day. So this is easily manageable, once a day treatment. So patient come to you daily for a single shot of ceftriaxone and 3 doses of oral metronidazole. Question number 46. What test should be performed to differentiate between acute and chronic hepatitis? Chronic and acute hepatitis cannot be differentiated most of the time as it is. This is based on the time frame of 6 months or 24 weeks. The other thing is for acute hepatitis, your LFT can differentiate. Your ALT would be in thousands, like 1200, 1500, 2000. In chronic hepatitis, they may be in a borderline range of slightly high. So the cutoff for male is 50, so there may be 70, 80, 90, but not thousands. What are the clinical findings on examination in acute conjugated hyperbilirubinemia? So acute, this is also called obstructive jaundice. For obstructive jaundice, you may have itching, you may have fever, you may have weight loss, you may have, and the jaundice as a foremost cause. And then on ultrasound, you can get intra or extrahepatic bile duct obstruction or intrahepatic dilatation. Next question is, what is the time duration For labeling jaundice as acute or chronic, I told you 6 months, 24 weeks. Question number 49. Patients with jaundice should be referred immediately, or cause should be evaluated. It depends. If the patient is very toxic and you're thinking that this patient need emergency medical attention, refer them to the hospital ER. Otherwise, you can treat at your level and do the workup. What are infiltrative disorder? Infiltrative disorder, the liver is infiltrated with any metabolic phenomena, or like the commonest infiltrative disorder of the liver is fatty liver disease. So the fat infiltration in the liver causes fatty liver. Otherwise, this could be iron overload, this could be copper overload, and several other reasons. Question number 51. What dietary precautions should be taken by patient with jaundice? This is a repetition of the question. No specific precautions except that don't avoid and basically avoid very rich food, greasy, fatty meal, but not don't get to a FACA state. Question number 52. How long neonatal jaundice can be taken as physiological? 3 to 5 days as a physiological jaundice. Other than that, consult your pediatrician. 53. What are the main causes of jaundice in Pakistan? Commonest causes hepatitis B, A, and E, and then hepatitis C, because most of the time hepatitis C jaundice is rare. Question number 54. Patient with hepatitis C treated, how often should be tested to be repeat? Test should be repeated, and what are the chances of recurrence? Very good and relevant question. The hepatitis C, this was not the lecture, but yes, hepatitis B is treated, and once you treat, majority of the time with new drugs, the cure is in the range of 95%. Once you get PCR negative at the end of the therapy, stop therapy, and then you check them after 12 weeks, 3 months down the road, once you have stopped therapy. And then if they are negative, then this is cured and you don't need to repeat again. Question number 55. How to manage hepatitis B and C in pregnant women? As I mentioned previously as well, for pregnant women to prevent transmission of hepatitis B, in the third trimester, you start them on NUCs, nucleotide analogs, nucleotide inhibitors, like either you give them tenofovir in third trimester, 300 milligram once a day to prevent transmission, and then once the baby is delivered, at one hand inject with hepatitis B immunoglobulin, other hand inject with hepatitis B vaccination. That's how you can prevent transmission of hepatitis B from mother to the neonate. For hepatitis C, you don't need to treat hepatitis C in pregnancy to the mother. The chance of transmission is very low, and take just universal precautions. So, question number 56. Yellow discoloration of sclera is seen in jaundice. Does it helps out in differential diagnosis, or it is present in every disease causing jaundice? Yes, yellow sclera is majority of the time is because of jaundice, and you cannot differentiate the causes. Question number 57. What is the difference between qualitative and quantitative PCR? And in this condition, we have to choose PCR, qualitative, quantitative. Quantification is the viral load, or you are asking your lab to get to the specific numbers, whereas qualitative is reporting you as the virus is present or not present. So the report may come to you as hepatitis B DNA detected, or hepatitis B DNA not detected in qualitative, but in quantification you can get hepatitis B actual value as 10,000 international unit per ml. For hepatitis C, which is the best test to diagnose acute stage? For hepatitis C, acute stage is very, very rare. You cannot diagnose as such. The only thing is with hepatitis C antibody, but majority of the time in acute hepatitis C antibody takes some time, so this is not present. In that scenario, you can check with hepatitis C viral load, or HCV RNA. Question number 59. Patient with liver transplant can live a normal life later on, yes. And are there any precautionary measures that has to be taken after transplant? For after liver transplant, they should be on immunosuppressive therapy for lifelong. Yes, the requirement goes down with the passage of time, but they should be monitored for the side effect of the medicine, for blood pressure, for hyperbilirubinemia, for blood pressure as well as for lipids. They can get mood swings, mood change, so they should be on a regular follow-up with somebody. Question number 60: is giving Neurobion tablets a good idea to protect liver damage for patient who is on anti-tuberculosis medicine? No, there is no data to suggest this. The only thing that is protective is neuroprotective is not Neurobion, but you give thiamine for alcohol and B6, vitamin B6 to have less toxicity with INH. How obesity and diabetes contribute to liver damage? They do contribute, as I have mentioned about fatty liver disease. So both are the risk factor for fatty liver disease, and then they get NAFLD and non-alcoholic fatty liver disease or NASH. Question number 62. Please explain about the vaccines for hepatitis A and B with booster dose in adult. I have mentioned in the previous question. Question number 63. How a physician and dental surgeon can protect himself from getting infected with hepatitis B and C infected patient apart from adopting safety measures like wearing gloves and masks? Again, the repetition of the question, I've answered this. Question number 64. Patient who is on lifelong mandatory immunosuppressive, what measure can be taken to protect him from hepatotoxicity? Which enzyme is more likely to increase in this specific case, and what is maximum level to get alarmed? ALT is the thing you need to monitor. If your ALT or total bilirubin is getting up, refer them back to the transplant center. They are going to monitor. Question number 65. In a patient with hepatitis C, how do we interpret the result of hepatitis C antibody test in terms of reactive and non-reactive? Kindly elaborate. Hepatitis C antibody test is the first test to be done for the screening of hepatitis C. If this is positive, this suggests that the patient was exposed to hepatitis C. This may be a current infection or this may be treated infection, but still after treatment you get PCR negative, but still your hepatitis C antibody is going to be positive lifelong. When is PCR recommended and why it is considered better than cRNA quantitative test? PCR quantification is better than qualitative. So PCR and RNA are the same thing, the different names. PCR is basically polymerase chain reaction. This is the process, and to detect RNA. Question number 67. Please explain about the vaccines for hepatitis A and hepatitis B with booster dose in adult. The third time this is the repetition. We have answered this. 68. Which protective globulin should be given prophylactically in dealing with known case of hepatitis C while doing dental surgery? No role of immunoglobulins or any globulins that should be given to patient with dental surgery. Question number 69. What should be the best possible way a jaundice patient be managed at GP level before referral? So a jaundice patient, it depends on what is the cause of jaundice. If this is obstructive jaundice, which means either because of tumor or stone, you need to refer them as soon as possible to the gastroenterologist who is going to offer ERCP and definitive therapy. For acute hepatitis, majority of the time this is treated at GP level. So you are the one who are going to take care of this patient at your home or your clinic, and if they deteriorate, refer them to tertiary center. Question number 70. Can take multivitamin non-alcoholic fatty liver disease? Multivitamin has no role in NAFLD. Question number 71. Please explain management this and dietary medical restriction in non-alcoholic fatty liver disease. We have discussed management of non-alcoholic fatty liver disease. Question number 72. What is the mechanism behind drug causing cholestatic jaundice? So there are different drugs which can cause cholestatic jaundice, and the different mechanism. There some are reacting with P450, some are directly toxic, some are causing bile duct vanishing syndrome. So there are different ways your drug can react and cause cholestatic jaundice. Question number 73, kindly elaborate how to manage the patient, how to manage patient with CLD. This itself is a topic for your training maybe. Uh, First of all, for chronic liver disease, address their immediate needs like ascites, encephalopathy, varicose bleed. So we are not going to discuss in detail this topic because the question is the topic was LFT interpretation. So question number 74, if someone gets pricked with hepatitis B or C positive patient, what immediate steps should be taken to prevent the spread of infection? First of all, you should ideally, if you get pricked with hepatitis B, you should be vaccinated. There is no excuse that being physician, we are not getting vaccination. So everyone should be vaccinated to protect ourselves, and you should be proactive in this, that everyone of us should be vaccinated. Then use universal precautions, which means gloves, masks, goggles, and then khuda na khasta, if you get pricked, then immediately wash this area, squeeze and take out blood as much as possible to decrease the viral burden. And then if you are not vaccinated, treat yourself with hepatitis. If the person is positive, check this person hepatitis B and C status, check yourself as well. And then at the same time, if you are not vaccinated, or your level of hepatitis B antibody is less than 10 international unit per ml, vaccinate yourself as well as get hepatitis B immunoglobulins to protect yourself from hepatitis B transmission. There is nothing that you can do for hepatitis C or HIV. Question number 75, what dietary advice should be given to patient who had cholecystectomy done? Nothing except avoid rich, greasy, fatty meal for initial 3-4 months. 76, as hepatitis A and E are self-limiting condition, what supportive treatment should be given to these patients? Address their dietary needs, address their vomiting, nausea, fever. No specific medicine is needed. Question number 77, how will we treat pleuritis in these patients? Given you answer that use also deoxycholic acid. Question number 78, what precaution should family members of a patient who have hepatitis B positive take? Everyone who is living with the patient with hepatitis B positive should get their blood test done for hepatitis B as surface antigen, as well as get hepatitis B surface antibody. If they have surface antigen positive but surface antibody, which is surface antigen negative but surface antibody positive, which means they are vaccinated or they got the infection but they are cured, they get the immunity. For those who have hepatitis B surface antibody less than 10 international unit per ml, get yourself vaccinated. Question number 79, what are the treatment management protocol for hepatitis B, A and C? This is a vast topic, we cannot answer right now. Question number 80, how important is it to treat non-alcoholic fatty liver disease in otherwise asymptomatic obese person, and what should be the treatment? Yes, we have discussed this thing previously. Address their risk factor, and you can treat with vitamin E 400 mg once a day. Question number 81, should all patients with gallstone be recommended to get surgery? No. If the surgeon is going to get all gallstone out from the female, this is going to be impossible for him or her. Question number 82, can hepatitis be transmitted through casual contact, sharing, eating, utensil, kissing, sneezing and coughing? Yes, for hepatitis A and E, but not for hepatitis B and C. Question number 83, is the vaccination for whole family living with the hepatitis patient important? Yes, they should be vaccinated. Question number 84, can jaundice go away if left untreated or can be complicated? Majority of the time, the jaundice is because of hepatitis A or E, this self-limiting disease, that go away. But if there are other causes, then you need to address that. Question number 85, is it possible to stop further progression of damage in cases of early stage of cirrhosis, compensated cirrhosis? Yes, you address the cause like hepatitis B or hepatitis B, treat them. You can prevent compensated cirrhosis into getting decompensated state. Question number 86. What are the red flag symptoms of deterioration in liver function in case of viral hepatitis, drug-induced hepatitis? So if your ALT is getting up, your bilirubin is going high, your PT is high. The important thing is PT and albumin. The albumin goes down and your PT goes up. That is the first indicator of you are in problem. Your patient is in problem. Question number 87. How can hepatic encephalopathy be prevented in case of hepatitis C infection? Hepatitis C infection itself can cause cirrhosis, can cause hepatic encephalopathy, can be prevented with rifaximin and lactulose. And you should give lactulose to titrate to have 2 to 3 soft stool in these patients to prevent encephalopathy. Question number 88. How a patient with cystic fibrosis can develop cirrhosis? Cystic fibrosis can develop cirrhosis in patients and this is basically genetic mutation. Question number 89. What percentage of patients in our country ends up in hepatic encephalopathy? What is the main cause? The main cause is any cause of cirrhosis, but here in Pakistan we have hepatitis C related disease. Question number 90. What is the ultimate consequence of fatty liver disease? Fatty liver disease is similar behavior, has similar behavior as any other chronic hepatitis B or C. So they may get trouble into chronic hepatitis leading to cirrhosis and then ultimately HCC as well as death and decompensation and leading to liver transplant. Question number 91. How can we differentiate between lucky Driscoll syndrome and breastfeed jaundice in neonates? Pardon me for my ignorance of this syndrome. I have to read and can get back to you. Question number 92. As Gilbert syndrome and Crigler-Najjar syndromes are caused by deficiency of the same enzyme, how can we differentiate between the two? Gilbert syndrome is indirect hyperbilirubinemia and Crigler-Najjar is direct hyperbilirubinemia. Question number 93. As constant rise in hepatitis C being witnessed nowadays and as its manifestation is quite vague initially, so what are the particular symptoms that we as a primary physician should focus on specifically while taking history? So take the history of contact, sexual contact, take the history of injection use, take the history of blood products and any surgery. Question number 93. What is the role of giving hepamers in acute hepatitis? No role. There is no role of L-ornithine L-aspartate, which is the generic name of hepamers. What is latent jaundice? Latent jaundice is basically when your ALT is high, but clinically you do not have yellow discoloration of sclera. Your bilirubin is less than 2 to 3. And question number 95. As regenerative capacity of the liver is enormous, so can non-alcoholic fatty liver normally after treatment will its hepatocyte revert to its original condition? Yes, if you are taking care of risk factor, they can get normalized. Question number 96. If the patient present with pruritus and complication of indigestion or reporting have fatty liver, what will be the management? Pruritus is different and fatty liver is different. You don't get pruritus and fatty liver disease. So if there is pruritus, address with ursodeoxycholic acid, and fatty liver disease managed with vitamin E. Question number 97. What complete treatment of hepatitis C? After complete treatment of hepatitis C and hepatitis B and negative test, what guidelines to be given as a GP and any further management needed? For hepatitis C or hepatitis B, if you have treated, the patient was non-cirrhotic, you don't need to put them on anything. But if the patient is cirrhotic for hepatitis C, place them on 6 monthly HCC surveillance, hepatocellular carcinoma surveillance, which is ultrasound every 6 months, and also get alpha fetoprotein every 6 months. For hepatitis C, hepatitis B, whether the patient is non-active or inactive carrier versus active disease or cirrhosis, you need to treat them, and you put them on surveillance with HCC every 6 months, despite they do not have cirrhosis, because in hepatitis B, this is called de novo cirrhosis, de novo HCC, which is seen in patients because this hepatitis virus gets incorporated in the DNA cause cccDNA, and cause HCC. So for hepatitis B without cirrhosis even or cirrhosis, put them on surveillance. Oops, this is more than 102. 98. Question 98. How long after hepatitis the liver function tests remain elevated? It is going to get down in acute hepatitis in 2 to 4 weeks time. Question number 99. Liver enzyme at what level should raise an alarm and should be further evaluated especially. There is no limit like 30, 35 of bilirubin, 2000, 3000 of ALT. It depends on what is the cause of that leads to this. What precautions should be taken after completing hepatitis C treatment? So prevent recurrence, universal precautions, avoid blood products, unnecessary injections to get a repeat infection. So we have crossed century, and now this is 101. If PCR is negative after treatment, the person is labeled 100% cured, or there are chances of recurrence. If PCR for hepatitis C is negative at the time of after completion of therapy, and this is negative after 3 months of therapy, the person is declared cured. But for hepatitis B, you cannot declare them cured. Keep them on follow-up. Question number 102. Why pruritus occur in intrahepatic or extrahepatic obstruction? Because of the raise in acid level caused by your bilirubin. Question number 103. How to assess a patient with deranged LFTs but normal clinically? So the deranged LFT but normal clinically could be just a stone, a recurrent stone, or a small stone causing blockage, or sometimes majority of the patient with chronic hepatitis, they are asymptomatic clinically, but you can get derangement. Question number 104. What is the importance of GGT, gamma GT? Gamma GT is raised in medicine. This can be raised in obstructive jaundice, or this could be raised in drugs and alcohol. Question number 105. What is the normal ratio of AST, ALT, SAB, GGT, and all of these are secreted from the liver? Yes, all of them are secreted from the liver. AST, ALT ratio are ALT is high as compared to AST. If AST is high, then this is mitochondrial damage. ALT, in my talk, I've mentioned that this is cytosolic enzyme. This gets elevated in hepatocyte damage, whereas any injury to the mitochondria, any ischemic injury can raise, you can get raised AST, so the ratio gets reversed. Similarly, the ratio gets reversed in alcoholic injury. Question number 106. Nowadays, hepatitis is very common in Pakistan. Then how to rule out patients if they present in early stage, and how to treat? As a GP, nowadays hepatitis is common. Yes, B and C both are treatment recommendation available, and probably you are going to get some lecture on hepatitis B and C by some of my colleague. Question number 107. Should bed rest be advised to a child with hepatitis A? Any dietary restriction? Do family members need to follow any precaution? No, not as such that you advise them bed rest, but they should not overexert. There is no dietary restriction except that they should avoid very rich and high greasy fatty content. Family member need to be precautions. Yes, they need to be cautious about hygiene of the baby or child, because this infected person is secreting virus from his or her stool, and that if that get contaminated, you can get infection. 105, a very lengthy question. Fatty liver with mild or moderate raise SGPT, negative viral marker, and hypercholesterolemia is a very common finding in today's world, especially in people who have central obesity and long office jobs. How to manage such cases? What pharmacological and non-pharmacological measures should be advised, and how frequent they should be followed? So this is possibly fatty liver disease, NASH. ALT is high. Advise them to reduce weight, increase their activity, brisk walk for 40 minutes a day for 5 weeks, 5 days per week, and treat hypercholesterolemia. Question number 9. How to manage pruritus in pregnancy? The same question we have answered with orthodeoxycholic acid. Thank you very much. So these were 109 questions, and the books you can read any textbook of medicine, which may be Davidson, which may be any good book. And I am thankful to the foreign trainees for their questions. Dr. Talat Mustafa, Dr. Sadia Jahangir, Dr. Taskeen Zahra, Dr. Sadaf Amir, Hina Naz, Misbah Farrokh, Shazia Mehdi, Tasneem Kausar, Shabana Zeenat, Shazia Javed, Mariam Iqbal, Abida Nasser, Hira Faisal, Dr. Ayman Javed, Naveed, Lubna Imran, Adia Ahmad, Sabi E. Fatima, Madhiya Faizan, Aisha Manzoor, Sayyida Ayman Anis, Fatima Zafar Alam, Mubashra Islam, Nilofar Hassan, Saima Badar, Kainat Ilyas, Dr. Sadaf Amir, Rabia Fatima, Huria Noman Sheikh, and Dr. Seema Salim. And forgive me if I have pronounced some name wrong. And this is the end of the live question and answer session for e-lecture, evaluation of patient with jaundice and management. Thank you very much for your patient listening.